So I think we'll go ahead and get started. I want to welcome everyone to our second webinar on PFE. Today we're going to be focusing on the Patient and Family Advisory Councils. Today our presenter will be Chrissie Blackburn, and she's an active patient advocate for patient and family engagement for the last 9 years, with experience as a parent of a medically complex child, and also avid partnerships with many healthcare organizations such as CMS, Partnership for Patient Contracts, multiple speaking events, including keynote presentation at the National Patient Safety Foundation, participation in IOM roundtables, development, structure, and execution of Patient Family Council program across an 18-hospital system in Northeast Ohio. And she has published articles, training and mentoring of volunteer patient family advisors, and she works with executives and senior leaders on implementation of PFE strategies and programs. In addition, she is executing the PFE learning sessions for OHA. Her current position is Principal Advisor of Patient Family Engagement, University Hospitals in Cleveland. She has a master's degree in healthcare administration from the University of Phoenix. With that, I'd like to go ahead and turn it over to Chrissie. Next slide.
Thank you so much, Rosalie, and welcome everyone today to another webinar around all of our efforts in executing patient and family engagement strategies. Today, we're going to be focusing on patient and family advisory councils, the beginning structures and its major components, the involvement and the importance of volunteer services within your organizations as it pertains to PFACs, and how to identify an owner of the Patient Family Advisory Councils, its membership and leadership. Next slide, please. So as we shared in the webinar in January, we went over the 5 different metrics around patient family engagement from CMS. So today we're just going to revisit metric 4. Hospital has an active patient and family engagement committee, or at least one former patient that serves on a patient safety or quality improvement committee or team. So as you look at this work, patient and family councils have a myriad of different titles. So whether it's an engagement committee, advisory committee, partnership committee, the components and structures are still the same. Next slide, please. So I think first and foremost, it's important to discuss what a PFAC is. So really, it's an advisory council that is a formal group that meets regularly for active collaboration between clinicians, hospital staff, and patient and family advisors on policy and program decisions. This is just one of many definitions, but many will talk about how it is a formal group and that it really is about collaboration and partnership. Next slide, please. And just as important is what is the patient and family advisor. A PFA is a former or current patient and family member of the hospital who is emotionally, physically, and mentally ready to volunteer and partner with the organization to make improvements. This is typically a patient who is interested in being actively involved in their care or the care of a family member and has offered constructive feedback in the past. So there's a lot of important components in this definition. And when we talk about someone who is emotionally, physically, and mentally ready, I'm going to give you a little bit of background on my story. My daughter was in the NICU at the Naval Medical Center at San Diego, and once we had come back here to Cleveland and she had stabilized, I was ready to give back and wanted to join one of the family advisory councils. And the nurse manager of the NICU, after about this was about 5 years after my daughter was born, said, would you like to come and tour the NICU? We had just redone it. It was state of the art. And of course, I was very interested. So I arrived the day to do the tour, and we went upstairs to the NICU, and she opened the door, and I lost it. You could say it was post-traumatic stress, the smell of the NICU, the sights, the sounds. all came back, and I was not emotionally ready to be on the unit. Now today, working in that same facility, I'm able to go up there, and although I was ready to partner on the council, I wasn't ready to be more involved in some of the other areas that pertain to my daughter's care. So physically ready, we want to make sure that patients and families are feeling their best health possible. I've had experiences where we actually had an advisor who was having chest pain during a council meeting and didn't tell anyone, and then took herself to the emergency department after the meeting. So really making sure that people are aware of their physical health and are going to speak up. Now granted, she was okay, but we want to make sure that people are at the best health that they possibly are. And mentally ready, when we talk about patient and family members that maybe had a negative experience within the hospital, whether that was a medical error that occurred or something else, we really want to make sure that they are ready to come back and are in a positive state of mind to be ready to collaborate effectively. Next slide, please. In addition, we need to talk about what a PFAC is, and it's really a council made up of loyal and collaborative patients and families and staff that want to help other patients and families really navigate the healthcare system. They support and believe in patient and family-centered care and patient and family engagement. The patient-family advisors offer advice, thoughts, ideas, and opinions based on their experiences at the hospital, but they are also thought leaders. Many of them bring their own set of skills and expertise from their professional lives. I can tell you the amount of advisors I've worked with. Some are physicians, some are lawyers, some are in marketing, some are in banking. And so they really do have a good set of organizational skills to understand the different hierarchy in politics and healthcare. Patient and family advisors are also responsible and professional, and they want to give back to their hospital and their community. Next slide, please. A PFAC is not a group of angry patients and families. It's not them taking over and telling the hospital and its staff what to do. And it's also not patient or family members out for their own agenda. It's not patients and families who have no understanding of the healthcare system. They usually do have a pretty firm grasp. And it's also not patients and families spending the hospital's resources. Next slide, please. So since we have gone through some of the definitions, we're going to talk a little bit more detail about the structure and the guidelines for patient and family advisory councils and how this can help in sustainability and development of your group. So first, we'll talk about PFAC membership, the roles and responsibilities of patient-family advisors and staff, the time commitment, the mission and vision statement, bylaws, or sometimes also called a charter, budget considerations, annual goals, and strategies for successful meetings. Next slide, please. So when looking at the membership, it's critical that we look at diverse patient and family advisors. The council should be reflecting who the community is in which the healthcare organization is serving. I can tell you from my own experience, being on a council myself at a hospital, I walked in and the majority was middle to upper class white women. And here at main campus of where we are in Cleveland, I can tell you that is not the majority of the people that we are serving. So making sure that we are looking at socioeconomic background, race, ethnicity, religion is going to be critically important, and also the diversity of the diagnosis or the disease. It can become extremely top-heavy in the experience I had in pediatric cancer care, but looking at a majority of different diagnoses is also important. It's also important that you have executive and or senior leaders that are participating regularly on the council. That's not to say that your president needs to be attending every meeting, but if they do choose to, that is wonderful, and it really does help to make the connection between administration and the group. Many senior leaders that sit on councils regularly are nursing, operations, and even your chief medical officers. It will also be important to have nurse managers or bedside nurses, physicians, and if physicians aren't able to sit on the council regularly, a rotation or inviting physicians to come and participate. Social work, your volunteer administrator or volunteer coordinator within your organization. And ideally, once you have your group up and running, the PFAC should be about 60 to 70% patient family advisors and 30 to 40% hospital leadership and staff. Next slide, please. So the time commitment is, we're really going to look at the average number of meetings per year and the duration. I know many councils that start off meeting quarterly, but ideally you want to be meeting 10 to 12 times a year or at least monthly. The reason for that is to not lose momentum and to make sure that the group is coming together often. In addition to that, with people coming together that often, you want to make sure that there's also activity that is happening between the meetings, because even though you can meet for 2 hours, if nothing is happening, it can be very difficult to execute what needs to be achieved. So there's usually about 2 to 4 hours of quote-unquote homework between the meetings, and to make sure that there's an appointment of action items at the end of each meeting to staff and to your advisors will be important. Some of the incentives for patient and family advisors vary. And the incentive might be that they simply just like to give back, and the hospital helps them or their family member get well, and it gives them a sense of well-being to be able to give back to the organization. Others might be, a hospital bag with a logo on it, or a complimentary meal during the meeting, or free parking if your institution has patients and families pay for parking. Your PFAC term limits can average anywhere from 2 to 3 years. So making sure that when there's patient family advisors that want to volunteer for this role, that they understand that there is a commitment is critically important. It will also help to ensure that you have new eyes and new patients and families that have opportunities to come onto the group and have other patients and families rolling off of the group as well. So with that, there's also additional activities for patient and family advisors, and further along in the webinar, we'll talk about what those are, but some of those things might be rounding on inpatient units. It might be speaking at different meetings or orientations of new interns or nurses. They might be looking over different patient education materials or working in ad hoc groups within the hospital. Next slide, please. So your PFAC bylaws are also important, and it's important to have these for a number of reasons. One, it keeps the group structured. Two, if you have any sort of incidents that come up, you can always refer back to the bylaws. I can tell you we did have a patient family advisor who was sitting on a council for quite some time, over 8 years. And the council wasn't really abiding by their bylaws, but it was time for her to come off of that group. She had her own agenda. The group was very uncomfortable when she was participating in the meetings. And in order to ensure that we let her go in a way that was professional, we had our bylaws to fall back on. You can also do this when you bring on a new advisor. You can have a 90-day period where if it's not going to work out, it's okay to let them go. So you want those bylaws for the eligibility for membership and outlining what that is going to be. Some of those things might be that you needed to have care within the organization within the last 5 years. Healthcare is changing all the time, and the delivery of care is changing. In addition to that, you would also want to make sure that there are no formal grievances that are unresolved. So some of those very, very important components and eligibility guidelines will help you in bringing on those patient and family members that are ready to participate. We've already talked about the term limits, but making sure that those are embedded into the bylaws as it pertains to the example I just gave you about the woman who did not want to come off the group, and also the meeting schedule. So everyone is aware of how often and the frequency of your meetings. In addition, you will have your roles and responsibilities for patient and family advisors, the required training and orientation. So there might be a volunteer orientation or a patient family advisor training that will help them to be an effective partner on different committees in the council. And also the expectations for the patient and family advisors, understanding that they will be expected to attend each meeting. They will be expected to carry out action items between those meetings. And, but in addition to that, really understanding what that patient and family advisor is passionate about enhancing in healthcare and what their time restraints may be will help to set the expectations for each individual advisor. You'll also want to implement the annual and other review process. So how often will the bylaws be updated? And of course, the mission and the vision of the council. Next slide, please. So strategies for successful meetings, and although this may look very elementary, it's important to know that as patient and family advisors join councils, they are not fully aware of who everybody is, and that includes other patient and family members and different guests and different staff and leadership presence. So making sure that everyone introduces themselves in the beginning of the meeting and having your senior leadership presence and presents and discusses organizational goals and priorities is important for alignment. Table tents with name and role. You want to make sure that your goals for the year are reviewed and visible at every meeting, and also discussing how far along they are in the progress of meeting those goals. Your staff liaison and patient family advisor co-chair will be leading meetings, and we'll get more into detail around what the patient and family advisor co-chair is, and also the staff liaison. And making sure that it's more work and less presentation. So I would look at if your average meeting is 2 hours long, maybe you have 1 or 2 people come to present a presentation, but you spend the rest of your time really working on a project. It's also important in the expectations of the patient family advisor that they know this is a working group and not a support group. I can tell you with the amount of time I've had participating on councils and facilitating them and working with advisors, people can get stuck on their stories. The staff can get stuck on stories. So making sure that you have a good facilitator in the staff liaison and patient family co-chair is going to be important to keep everybody on track. And you also want a timekeeper. So just like any meeting that we might be in, it's important that we know exactly we're following our agenda to the time so that we are able to get all the necessary work in that we need to get in. Next slide, please. In addition, we want to make sure that the agenda is put together with the input of the Patient Family Advisory Council, the staff liaison, and the patient co-chair. So the staff liaison and patient co-chair really work together in partnership in executing what that agenda is going to look like and also running the meeting. But keeping in mind that the PFAC is the Patient and Family Advisors Council. And as staff and leaders, it's us helping them to guide them on how to meet the goals that they want to meet, and also in addition to align with what the organizational goals are as well. You will want someone to record minutes. So whether that is a patient family advisor or you have the resources to have a secretary come to your meeting and take minutes, this will be important. It is very helpful to do this because you can see the progress of how you've been moving forward over a year's time, and it will eventually help you put together an annual report on what has been achieved. Also, at every meeting, there should be open discussion for ways to improve and other ideas for the council itself. And to close every meeting with time for questions, contact information of staff, different comments, and again, the appointment of action items to complete before the next meeting. I will tell you, in order to also really make sure that the council is successful, those that do come and present, or if a patient family advisor has an idea, it is extremely important to follow up with the council. If you don't follow up with the council, they begin to feel like their voice isn't being heard. And with that, explaining to them that sometimes healthcare is a slow machine will be important to set their expectations that it may take a couple months to follow up on certain ideas or initiatives. Next slide, please. So at this time, let's think about a couple of questions to consider. Think about your own organization. Maybe you already have a council, or maybe you're in the very beginning stages of wanting to develop one. Who might own your PFAC? And by that, I mean an executive sponsor. And why does your hospital want a PFAC? Is it because we truly want the patient family voice to be heard, or it's because CMS is telling us to do it? And who has an example of when it went well and when it did not? Rosalie, I'll defer to you for the chat box for any answers.
Currently nothing.
So maybe in the chat box, if our attendees could answer, do you have a PFAC started? Yes or no?
We got one, just a second.
Okay.
One says no.
Okay.
Another one, and a third one says, yes, our organization has one that is run by Service Excellence. And then we just have another person saying yes. So we have 2 yeses and 2 nos.
Okay. For the one that, for Service Excellence, if we can chat back, how is that working out? Have there been any barriers or concerns with the group?
Currently, she says it appears to be a robust group, but does not cover much about quality and patient safety.
Okay. And that can be a challenge for many of the patient family advisory councils. And sometimes that's some of the hesitancy of sharing what is happening around quality and safety within our organization. So we'll talk about some of that as we move forward in this webinar today. Next slide, please, Rosalie.
Just a second.
Okay.
Yeah. Okay.
Okay.
All yours.
So moving forward, you know, there are some barriers and concerns, and this is what Rosalie had learned and hearing from different hospitals across the state. And one is being a small facility with limited staff. They tried in the past and it didn't go well, you know, needing guidance to get it started and off the ground. And then the concern with confidentiality of the materials discussed at meetings, and having a patient on the committee being privy to confidential information and maintaining that confidentiality. So I would say with being a small facility with limited staff, in my experience, I've worked with quite a few small facilities, and it is able to be achieved, It's a matter of getting the support of leadership, and also the support of and finding a staff liaison, a PFAC staff liaison that is willing to help own the group. As far as trying in the past and it didn't go well, that again could be a number of reasons why it didn't go well. It could be time restraints. It could have been the work wasn't meaningful for the volunteers, and if work isn't meaningful for any type of volunteer, whether you're in a healthcare organization or not, they may stop volunteering. Guidance to get it started and off the ground. Absolutely, that's why we are here today, and why I'm working with OHA to help all of you to get that off the ground. And as far as the confidentiality of materials, we're going to talk further about the importance of volunteer services, but you can have, through volunteer services, background screenings, HIPAA training, confidentiality waiver signing, so that patients and families that really come back to participate and partner in this way have a strong understanding and know that they're not allowed to take this information outside of the hospital. And volunteer services can really help and educate why, and have them sign all the necessary compliance and legal documents for that. Next slide, please. So as we talked about with the importance of leadership, is really who from the executive committee should lead the strategy and mission for the PFACs. Most commonly, it is patient experience, more so today than it has been over the last several years, or quality. Usually sitting within patient experience, there's a drive of obviously improving not only your HCAP scores, but the overall experience for patients and families. You could easily put safety and quality under patient experience, and just in my own opinion, if you have a medical error that occurs, you've had a bad patient experience, and usually that leader is involved in multiple areas as it pertains to safety and quality. And then in addition to that is, how is leadership aligning health system strategies with patient family engagement and with PFACs? So again, is that aligning with your experience department or your quality department? And how are they sharing their goals with your council in order to produce effective outcomes? And how do you plan for alignment? In the experience that I have had, it's been important for the CEOs or presidents to come to the meetings typically during the time in which an organization is developing their goals for the following year, to get the input of the Patient and Family Advisory Council. Next slide, please. So with aligning with leadership and getting the buy-in, it's really determine the goals of the organization and where would the patient and family voice benefit the organization. Now, in my own work, I would say everywhere. The patient and family voice would benefit HR, they would benefit safety, it would benefit patient experience. But where does it feel safe within your organization for the time being? Many institutions start with patient experience because there's data to be shared, and the patients and families are really living the experience and filling out those surveys anyway. And then eventually, as trust is built in that partnership, moving them on to other committees as it pertains to safety and quality can be achieved. In addition, explaining to leadership the volunteer vetting process and confidentiality will be critically important, and we'll have a couple of documents for you that I'm sure OHA will be posting on their site, and how you can explain how that vetting process works. And also that really running a Patient Family Advisory Council is minimal as it pertains to resources and cost. So on average, a council may run anywhere from $700 to $10,000 a year. And it really is dependent on whether or not you're sending patient family advisors to conferences or to learn more about patient family-centered care, or if you're meeting and you need resources for paper materials and a complimentary meal. And responsibility could be a part of an existing FTE. So when we think back to the CMS PFE metric number 3, that there could be someone that proactively looks over patient and family engagement within the organization, but it's absorbed into what is already existing in their full FTE. Next slide, please. Medical staff involvement is a bit more of a challenge, but having a liaison and that staff liaison, or even a patient family advisor working with them and coming back and forth, can be helpful. But you'll need to provide some education. Some of the time, and when I've worked with physicians and they've been learning about what the councils are and what they do, there's some hesitancy. They want to know, who are these patients? Who are the families? How are we bringing them on? Is it a free-for-all, like anyone's allowed to come? And I could understand that because these might be people that they have cared for. So after educating them on the selection and the interviewing process and really what patient family engagement is, they have a better understanding and are a little bit more accepting of wanting to work with them. So explaining how the PFAC functions and inclusion of the PFAC during development stages of initiatives and how physicians can be a part of that, whether it's through email or actually participating on the council or with the liaison, is helpful with the involvement. And then how to meet with the PFAC and how to follow up with them is going to be important as well, as you explain the functionality of how the council works. It's interesting, as long as I've been doing this, when I'm talking to patients and families and when I'm talking to physicians, they really both want the same things. And obviously that's really good outcomes, but they want to also, have the time to communicate and talk with the patients and families. So working together to get to those goals is critically important. Next slide, please. So the patient family advisor volunteer application and review process, there's a formal process is absolutely necessary because you want to be able to screen for grievances and really a positive attitude and a collaborative attitude of that volunteer. There's a 2-step interview process with volunteer services, and then they also interview with the staff liaison and the patient family advisor co-chair. This way you have 3 different perspectives interviewing one person, and although that may seem to be overboard, it's actually very, very helpful, because although one of those 3 may think that that patient and family member is ready to participate, someone else's perspective may say, maybe not quite yet. So we've already reviewed that a background check, health screening, HIPAA safety training, compliance, and ethics training can be done through volunteer services. And I'm sure that many of your organizations already have a process in place for other volunteers. In addition, you could have a 12-month policy for patients or families that have had a less favorable experience before they can join. So I have recently, in the last couple years, we had a parent join our pediatric council, and her daughter was born with an extremely rare syndrome, and wasn't told that she would live much past 3 days. Well, her daughter ended up living to be about 6.5. And during her daughter's lifespan, she knew that she would outlive her daughter. And she had heard about the council prior to her daughter's passing, but about 6 months after her daughter's passing, she really wanted to join. So we did our due diligence, and we talked with her, and we interviewed her, and I also reached out to national colleagues. And her grieving had, although tragic and sad of losing her child, had been different because she had been preparing for this. And she truly lived every day to the fullest when her daughter was alive. So about 8 months after the passing of her daughter, we did invite her to join the council. She was ready to participate, and she has been extremely helpful working with grieving services within the pediatric hospital, and also our pastoral care services as well. So she's been a dynamo and wonderful to have on the group. In addition to that, when we're talking about developing our PFAC, some of the biggest barriers and concerns is recruitment. So being able to explain what the council is and talking to a variety of stakeholders from physicians, nurses, patient advocacy, and social workers, and self-referral will be important. I will tell you that some of your best people to refer will be social workers. They do get to spend a great deal of time with patients and families, and in addition to that is patient advocacy. So even though someone may have filed a formal grievance or just filed not a formal grievance but a complaint, does not put them out for not joining the council. Some are very well spoken and really do want to give back and find resolve to maybe some of the issues that they had, but realize that could be happening to other patients and families as well. And Rosalie, would you like to put up that flow chart? So we developed, okay, great. So we developed this flow chart to really help guide the different steps necessary in the interviewing process, and then what to do if a patient and family member is not ready to participate. And volunteer services is critically important to that component, because they can, one, it's their expertise in interviewing members that want to volunteer, but can also act as that HR. So they will be responsible for letting them know if they have been accepted or not accepted. Next slide, please.
Okay.
I think we want the next slide, Rosalie. I'm sorry, the why volunteer services. So the volunteer department really acts as human resources for the interviewing process and bringing on the volunteers, because patient family advisors are volunteers. It also gives a place where that patient and family advisor could go if they have any concerns around the council. That's a safe place. In addition, they also help with that formalized orientation process. So whether it's your background screenings or your HIPAA training, they also can get them oriented to your organization and looking at some of the rules and regulations as well. They also have expert insights on volunteers who may or may not be ready. So in interviewing patients and families for the PFAC, it's not so much what formal interviewing might be done with regular volunteers, but it's more behavioral interviewing, and there's a set of questions that's also within the OHA PFAC toolkit that can help volunteer services and your organization on what to ask when you're interviewing a potential PFA. Next slide, please. So the Ready Patient and Family Advisor. This came out of a conference I had been at a few years back with Solutions for Patient Safety. That's the pediatric HIIN. And there were about 10 parents at this, and we were holding a patient-family engagement learning session within the conference, and many of them were asking, well, who is the right patient and family member? How do we identify the right patient and family member? And the 10 of us came together after that learning session, and we said it's really not identifying the right person, it's identifying the ready person. So I came back and I put my thinking hat on and developed an acronym, because this is healthcare, so why wouldn't we have another one? And really determined that it's characteristics. It's someone who is respectful of the organization, they've experienced care within your hospital, they are appreciative of the other patient and family members, the staff and leaders, they are dedicated and loyal to the organization, and they are involved and want to give back. These are also important to look for as far as making sure that although that less than favorable experience may have occurred, that people can still have these characteristics when they have resolved what has happened within whatever their grievance might have been. Next slide, please. The orientation for patient and family advisors is also important. So we talked about the general volunteer services orientation, but also a checklist for patient and family advisors. This is also within the OHA PFAC toolkit to make sure that they are meeting everything that they need to meet prior to fully being onboarded and ready to roll on the council. In addition, you might want to do a hospital orientation. So I had only been to 2 units constantly for about 4 years with my daughter. So it was good to get a formal tour and learn more about what was at the facility and the other types of services that were offered at the facility so that I could be a well-educated patient-family advisor on the hospital. It's also important to provide them with who the leaders are in the organization. So each of our councils do receive not the formal organizational chart that might come through human resources or development, but the name of the president, the name of the CNO, the name of the CMO, and how to contact them. Also teaching them in that if you do want to reach out to someone at that high of a level, that there are some, there can be some politics involved. So ensuring that the staff liaison knows would be critical when it comes to reaching out at that high of a level. Also, their roles and responsibilities and understanding what those are also in the toolkit, and making sure that the staff liaison is accessible to them. So they may have questions or concerns or other things that they want to share within the organization. So the staff liaison needs to be prepared to be involved with those volunteers. Next slide, please. So this slide is very, very busy, and I'm not going to read through everything, but you can see from this there are many different roles and many different activities for a patient-family advisor. And some are beginner level to intermediate. So that might be simply starting to look over patient education materials or doing some rounding in the hospital, looking at wayfinding or signage, to patient and family advisors that are trained in public speaking and are speaking at national conferences or community events. So there's really, when you're looking at the roles, it's what are the skills that the patient and family advisor has, because I would not put a patient-family advisor up in front of a podium to speak if they were not comfortable doing that. And what are they passionate about, as we discussed before? I can't emphasize that enough. I knew coming in as a volunteer in my role that I was very, very passionate around safety and communication at the bedside. So as I got to know the staff liaison and she got to know me, she was able to guide me and connect me with different leaders and people in quality to talk about the ideas that I had and how we could move those forward. Next slide, please. Some of the main responsibilities for your patient and family advisors are going to be some of the obvious: to maintain professional and passionate about the work you're doing, to respect and listen to those around you, to be timely, to acknowledge that conflict will arise within the council and how that can be resolved, to be a team player, to follow through. So if you say you're going to act on something, you've been given an action item, that you will follow through on it, to use your talents and skills, and to ask if you don't understand. So again, in the toolkit, there's a more formal layout of what those responsibilities are for the patient-family advisor. Next slide, please. So with the Ready Patient-Family Advisor, this is also a guide for you in how to determine who a Ready Patient-Family Advisor co-chair may be. So this is someone who is respected by the other PFAC members and the organization's staff. They have the skills to execute the mission and the vision of the PFAC. They're accountable for the PFAC, the patient-family advisors, the structure, the activities, and leading, supporting, and assisting in the PFAC goals. They really become the face of the council within the organization. They also have the drive and is well connected with the help of the staff liaison to other hospital administrators and staff. And they're inspirational and set by example the roles and responsibilities of a patient family advisor. One of the PFACs I worked with that has been around for quite some time, like any council, ebbed and flowed, and needed some new energy and restructuring. And just this past year, they celebrated a very lengthy anniversary. But prior to that, about 10 years ago, the patients and families that were sitting on the group, because there was no formal structure of interviewing, really combated with senior leadership. And because of that, there was very little support in working with the Patient Family Advisory Council. Once this council had developed some new energy, we had put this formal process together in interviewing candidates, and we identified a patient family advisor co-chair. I can tell you through coaching and working with them that they very successfully, and it took some time, about 3 or 4 years, restored the relationship between the PFAC and senior leaders. And it really was tremendous to watch and to see how it's really helped them to become more involved. So that patient family advisor co-chair can be the inspirational person to help with the connection between leadership and also how to role model for the other advisors on behaviors and how to act within leaders and on the council as well. Next slide, please. In addition to that is the Ready Staff Liaison. So the staff liaison usually is very respectful of the patient family perspective. They are well connected and engages and educates advisors on how the hospital works and staff and clinicians on partnering with patients and families. They lead and appreciate and champion patient family-centered care. They have patience and are dedicated to learn perseverance, strength in all people in all situations. And they also look for and identify opportunities for advisors to be involved in throughout the organization. I will also say that this person, they could be clinical or administrative. Typically administrative is ideal, not that we have more time always as administrators, but it's very difficult for clinicians to find the time to be accessible to the volunteers and to execute on different initiatives or projects or action items. So this person would also be have good relationships with both clinical and administrative staff and a good facilitator. So we talked about that before, how patient family advisors can get stuck on their own stories or the staff. So having someone who has the skill to redirect conversation is critically important. Next slide, please. So some of the roles and responsibilities of the staff liaison is really, with hospital leadership. So how are they keeping them informed of what is happening with the council, and also getting their buy-in and commitment to be involved with the group. The responsibility to staff and clinicians is to educate the advisors and opportunities to work with them. For staff development of plans for involving the PFACs, helping staff understand how to interact with advisors and how to implement their suggestions or provide feedback about why changes may not be possible, and problem solving in challenging situations. The responsibilities to the PFAs are really obtaining necessary resources and cultivating opportunities for involvement, overseeing recruitment and selection, communicating with the PFAC in a timely manner about recruitment status and potential opportunities, overseeing PFAC activities and facilitating the ongoing engagement of the groups, and bringing concerns of the PFACs to leadership or connecting advisors with leadership, and tracking and communicating the PFAC accomplishments. Some of this patient family advisor co-chair will also assist on, particularly as it pertains to the responsibilities of the patient and family advisors. Next slide, please. So for those of you that maybe are just in the beginning of your journey, what could you do next Tuesday? And here's some suggestions to talk to some of your colleagues that you think might be interested in interacting with patients and families, and also to volunteer services to learn more about what they're doing and how they function within your organization. You might want to think about who would be the appropriate staff liaison and wanting to bring on that role. I will tell you also that some PFACs have a co-facilitator staff liaison, so there's 2 people as staff liaisons as opposed to 1 that can really help each other and share the workload. And then maybe plan a strategic approach to talk with leadership. So what are the things that you might take from this webinar today and put together so that you could start that conversation with your leadership team on how to support a patient family advisory council? And what if your organization already has a PFAC established? Where do you go from here? What other opportunities might you begin to explore? Maybe it could be as simple as having some of your patient family advisors come and speak or talk to different staff or administration about their story or the role and function of the PFAC. Or maybe it's taking the next step and seeing what can be done of placing a patient family advisor onto a committee. Sometimes the place that these advisors go when you're getting started with more interaction on hospital committees is a service excellence or patient experience committee, or a overarching quality committee, where it's not in the trenches of doing the work or a task force, but on that broader committee where you might be reporting out on some different data and initiatives, and just having that patient family member there to ask questions can be helpful. Next slide, please. So I am aware that this is a lot of information, especially if you have not readily engaged with starting your patient family advisory council, or this may be new information that you embed into your already existing councils. But I am here, I am available to you. You can email me, can help you work through talking with your leadership or working with volunteer services. But I'd like to open it up at this time for any questions that you might have.
Yes, and please either enter your questions in the chat box or the Q&A box. Either one is fine.
We have some questions coming up, Rosalie.
Currently, I'm not seeing any. We'll just give it another a minute and then proceed. We just have one comment, and it said it's been a very helpful presentation. Thank you.
Great. Please feel free also to just reach out to me directly via email if you have questions that might be in more depth, and we can arrange it, either a time to talk or whatever is most convenient for you.
Right. I'm not seeing any additional questions, so Chrissie, I think we'll go ahead and close the session today. And like Chrissie indicated, if you think of a question later, feel free to email Chrissie directly for either a conversation or a quick question through email, either way. And with that, we'll end this session, and we will have another program next month. And thank you all for attending.
Thank you.